Good morning, everyone. I welcome you to yet another episode show of the Speech Hour. And today we will be talking about oral placement therapy with our very talented Shereen Idiculla along with us today. Good morning, Shereen.
Good morning.
So Shereen and I have known each other for a very long time, dating back to 2002. She was my senior at All India Institute of Speech and Hearing in Mysore, and I have some great memories with her professionally and personally interacting with her too. So both of us have been talking about oral placement therapy for some time, and we hope that this event today will add a lot of value to all the viewers today. Um, I'll first like to, a routine. I always do this. I'd like to introduce Shereen more formally to everybody so that you all know a little more about her. So Shereen is actually a speech language therapist. She finished her master's from All India Institute of Speech and Hearing, which is called as AISH in 2004. And she has an experience of over 14 years in the field of speech and hearing. She's a Hanen certified therapist. She's done both the programs, the More Than Words and the It Takes Two to Talk program. She also happens to be the only level 3 oral placement therapist in India. Professionally speaking, she's the director of clinical services at Play Street, which is specially able to educate trust, and she's also the co-founder and director of an inclusive preschool called Kid Street in Bangalore. And I think a lot of our viewers today maybe are her, the parents whom she meets on a daily basis or the therapists she has trained. She also happens to run many online programs to help parents on different aspects related to children's development of language, cognition, feeding, chewing, etc. And she uses Hanen strategies for language interactions and OPT for oral and sensory skills. So that's just a brief overview of the so many years that have gone into making Shereen the therapist she is today. She travels extensively to attend all these programs, and she's learned the finest of strategies from senior people in the field of speech and hearing. Thank you for taking out time for us today, Shereen. Thanks a lot.
Yeah, thank you for inviting me for this. It's going to be an experience, I think.
Absolutely. So we've had an overwhelming response for this event, and we were not expecting that it'll surpass our expectations. And hence, what we've done is, because we do have a time limitation, we've have already asked people to send us their questions, and so that we will try our best to answer as many questions as we can today. But there's always opportunities to learn again. You can connect with Shereen even later, and I'm sure she'll be able to help you out. Okay, so starting with the agenda points for today, I hope everybody, I'm sure everybody is all ears and they really want to know. So, Shereen, very basic. So what exactly is oral placement therapy? So say a parent watching this video does not know what it is. So what is exactly OPT?
Okay, so oral placement therapy is more of a specialized speech therapy technique, and it works on improving the oral structure placements and the movement patterns for speech with respect to speech clarity, speech production, and for feeding development. So it works on all 3 components. Traditional speech therapy looks at, look at me, do what I do, or say what I say. So it's a more auditory and visual way of learning. What OPT does, it adds another component, touch, to help the child understand or the client understand what exactly they need to do. So because speech is a very tactile, proprioceptive move, that's how it's based. They've added this component in to help clients understand what they need to do, what pattern they need to form, etc., so that they can create those sounds and move into combinations, etc. Right. So in a nutshell, that's what it kind of works on.
Right. Okay. So, when I was studying and during my practice also, we've heard a lot about oral motor therapy. So is oral motor therapy same as oral placement
Right. So
therapy?
initially, about when it was created by a lady called Sarah Rosenfeld Johnson, and I'm so happy she
Yeah.
did create this because it kind of helped fill in a lot of blanks. So initially, when she we've all taught oromotor therapy, like you said. So she was taught the same thing about 40 years ago. And when she first came out with her book, it was called Oromotor Exercises for Speech Clarity and Feeding. But later on, what she realized was oromotor therapy is a very vague term. It's an umbrella term. So
Yeah.
what she changed it to was oral placement, because what she's actually doing is working on placement of the oral structures for speech, in specific for speech, not just movements, creating movements which are not speech based, but creating movements that are needed for speech and for good feed development. So that is why so it's not oromotor therapy in the sense what we learned, because there's a lot of difference. The rationale is a little different. So if her whole program is based on the rationale on how muscles develop, what the typical development of the jaw, the lips, the tongue is, and then based on that, she has created this program that helps us develop those muscles hierarchically so that the child does not fail later when the child has to speak, say, in a 3, 4, 5 word sentence. So in isolation, we might have a sound. Traditional speech therapy, we can do that. We work on phonetic placement and we say, look at me, say, for example. But when the child has to go to word and sentence level, sometimes we see clarity going down considerably. So she has looked into all those factors. And that's one of the reasons she created this program, because over 40 years ago when she started, she had about 74 clients with her. And these clients did very well with their language. Over a year, the MLU, the mean length of utterance, improved considerably from 1 word to 3, 4 words. But what she realized was the clarity was a lot better a year before than what it was at that time. So there's something definitely wrong here, because their language is improving, they're speaking more, but you can't understand them. So that's when she started researching about what it could be. And it was an occupational therapist and a physical therapist, actually, who kind of helped her put things together and realized that muscles, the function and structure of the muscles is what we also need to work on to help. Right. And that's a big component that I feel is missing when we look at speech therapy in general.
Yes. No, I agree. I agree with you. I agree with you there. So I also, my research tells me that I had put a picture of Sarah for everybody to see. Yes. So I'll take that off. Okay. So I also believe that she has coined the term oral placement disorder, because that is something not everybody knows about. So so if you can tell us a little more about what oral placement disorder is it some new category of disorder, or is it prevalent in children whom we see for speech therapy, or if you have any information?
Again, it is about the placement. Now, she has coined this with respect to oral placement therapy when she created this. So those children who are not able to look at you and make movements or imitate you easily would probably fall under that category of oral placement disorder. They would have maybe they might have a sensory issue, they might have oral sensory issues, they might have oromotor issues, they could have feeding issues, and they could have speech issues. There are 4 components there that kind of together you would say oral placement disorder if they have issues in any of these areas. So it's mainly about the placement of the structure, the oral structure.
But it's different than apraxia, or say apraxia has an overlap with OPD.
Yeah, apraxia definitely has an overlap with this, because apraxia again is precision and clarity of movement, and the sequencing of movement, and a lot of those things. So it does work on that too, because a lot of children with apraxia may have sensory issues which we don't deal with. They might have feeding issues which we also and they definitely have motor issues because they cannot plan those movements or sequence those movements. So it works on all these small components, puts it together so that overall development happens rather than just one component being taken care of.
Right, right. No, it's very intriguing. So you said Sarah has worked on this for 40 years.
Right, over 40
A,
years.
that's a whole generation that she's done this work. So I'm sure she's done her researches and she's published articles. So what is it? I hear a lot on the controversy on it being evidence based or
Right,
not. What
right.
is your take at it?
Well, yes, especially in the US, there is a lot of controversy. There are two schools of thought that non-speech oral motor exercises will not help. I actually agree
Yes.
non-speech oral motor exercises won't help. But what it does is it works on the oral movements that are needed for speech and translates it to speech. That's what is needed. See, that's the difference. And I've been working on this for over 8 years now. And I have seen a big change when I introduce this with the children I work with. Because most of my children, I work with the pediatric population. So most of the children I worked with showed considerable improvement when I introduced this component in traditional speech therapy.
Right,
So
right.
it is definitely something that makes sense, because if you understand the rationale behind it, and that's what I try to explain to parents when they come to me, I said, understand where it's coming from. If you can understand why you are doing this, then you will be able to take it forward. If you're just going to do this blindly because a therapist told you, make the child blow, right, as just a skill, then you're never going to translate it to speech. So the understanding should be, why am I doing this movement? How does it connect to speech? And I'm hoping by the end of this hour that I will be able to kind of help you all understand that non-oral speech movements that are used in OPT have to be connected to speech. That's what makes OPT program. It's not just working on movement alone and stopping there. And that's what I see a lot of therapists unfortunately doing, because they're working on one component and they forget the second. And what I want you all to do, that you have to combine it, and that's when you get really good results.
Right. So what's that missing link which parents or therapists are not doing? So they are doing the oromotor exercises, they're doing traditional therapy, look at me, speak like this, look in front of the mirror, and trying to stimulate various areas. But what exactly is it the gradation, or is it, if you can throw some light there?
Right. So what I see generally happening, because when parents come to me after working with another therapist, what I generally see happening is they're working on the OPT program. They're working on non-speech movements. Fine. But what is not happening is it's not translating to a speech movement. So if I create a movement, for example, I have got lip closure. All right. And I'm saying, for example, with spoon feeding, I'd get lip closure to clear the food from the spoon. So if I've got lip closure, the sounds that I would immediately work with was But for children with apraxia, it might not automatically translate to a speech sound. For some children it might, but some children it might not. So they need to make the connection for the child so that it translates to a speech sound, and then you take it in a way that you can use traditional speech therapy, where you say, look at me, now you can imitate, okay, let's move on. So it's a component of a speech therapy program. It cannot be done in isolation. It has to be combined with traditional speech therapy, but at the stage where the child is ready.
Okay. All right.
So, for example, I wouldn't work on speech if the child is not creating any movement.
Right.
So,
right.
Connection.
Okay. So we have a lot of people who've joined us, and I'm very happy to see a good number already. So I'm just going to put their names up here so that so we have Henna, who's asked us how to be a certified OP, oral placement therapist. And we'll definitely come back to your question, Henna. We have Kritika saying hello, Sharpreet saying hi, and Prashanti and Sonali. How lovely to see so many people around. I think it's so overwhelming. It's Priyanka and Vidya. Thank you for the awesome response, and we hope, as I said, we hope with this discussion we can really add a bit more value to everybody watching this. So she says hello. How nice. Shireen, can we discuss now the candidacy for OPT? So does everyone need OPT? Can everybody be oral placement therapy?
No, not everyone needs, right? So there are, like I said, there are 4 components that you look at. So if the child has sensory issues, oral sensory issues. When I talk about oral sensory issues, it means, is a child very sensitive to tactile input? Is he, like, for example, a picky eater? He doesn't try a lot of food. He doesn't like people touching him. That's what we call hypersensitivity. Or do you see a child constantly seeking things and putting it in his mouth and mouthing objects, mouthing his t-shirts, not chewing his food? So there are different sensitivities that the child has in his mouth, and that's what we first need to figure out. If there are no sensory issues, we don't have to work on that. But if there are sensory issues, that's when we bring the OPT component in and work on that component, right? The next one would be feeding. So if there are feeding issues, if the child is not chewing, he's swallowing, he's choking, he's aspirating, there are so many issues that the child can have. He's uncomfortable with eating, if he's force-fed because you need nutritional intake. So when there are so many components like this that, and nutrition is so important for the health of the child, that would maybe be the priority, like, okay, we need to look at feeding and make sure the child is healthy before we even look at speech.
Right.
Another component. The other one is we look at oromotor movements. Now, is the child able to imitate? Look at me, say what I say, or do what I do. If you can do that and you can put it, then you don't need OPT. All right?
Yes.
If you see weakness in the muscles. Now, weakness is a little difficult to identify in layman terms. You might need a doctor or a therapist to kind of tell you that there is weakness. But generally, with the case of children with very low tone, you would kind of see an associated weakness with it. So in that case, if the muscular structure itself is weak, you are definitely going to have issues with clarity later on because the muscles are not strong enough to support speech. And finally, the thing is this, if you see these issues in any of these components, you can do OPT. If you don't see those issues, traditional speech therapy is good.
It's fine. Okay. So that's, I think, very good information. So there is definitely a candidacy. It's not that, you just want to do it with everyone. So which typically are the, the developmental disorders that come under this, candidacy? So we hear about,
I mean, pretty much, like I said, all the childhood language disorders can come or need not come. It kind of depends on the full muscular structure. So I have worked with children with Down syndrome, autism, apraxia. You can do it for children with traumatic brain injury or adults with traumatic brain injury. You can do it with Mebius syndrome, different syndromes. Wherever I've worked with a few syndromes too, where basically we're looking at the components here. Are they working together to help with the child's verbal speech? If it's not, then we need to go into detail and say, where is it stopping him? Is it the planning process? Is it the production process? Is it weakness? Is it sensitivity? We need to look at all those 4 components, and if they're all okay and traditional therapy can be used, we do it. So there is no limitation to what population it can be used on.
Okay.
It can be from pediatric to geriatric population. Post-stroke, you can use it even for adults. Because again, post-stroke, when there is a paresis, or they're not able to feel, or they're not able to talk, you increase the sensation they have so that they can try and make movements. So the population is endless. There is no specific population. It just depends on what the issue is.
Right. So we do have this question from Vinita, who once probably has a child with whom she's seeing with Down syndrome, and she wants to know if we can use OPT for feeding with this patient.
And definitely there is a horse on its own for just the Down syndrome population. It is definitely something that can be used for children with Down syndrome because of their low tone. Because of their hypotonia. Some of them have high sensory issues. So when they're not able to create those movements, definitely OPT will help. And there is also a free study on the Talk Tools website that Sarah has done, which talks about how the structure itself changed when OPT was started from birth.
Oh, wow.
So what we
That's
assume, there's a
interesting.
myth of Down syndrome that say, okay, they all have a large tongue, they all have this, they all have that, right? So what she's saying is, if you had actually worked on that from the beginning, the structure itself changes and you will not see those kind of typical Down syndrome features. It's a very
Right.
interesting study, which
Interesting.
actually
I'm
when
sure
I was there,
we will send a link in this event shortly, and you all can go over that video at your time. Okay, so we have more questions coming in. I think let's take them as they're coming. So here's Shalini. She's asking how to start feeding in a child with hypersensitivity.
well, it's a program of its own, but to anyone with hypersensitivity, you have to desensitize, right? That's the key. So sometimes a long process, it is a process, because if you force your way into the child's mouth when the child is not ready, he will not trust you after that. So whatever you want to do, however safe it might be, he will think it is something that is very dangerous for him. So the first thing to build is trust with the child, and the second thing is to slowly desensitize him so that he accepts the touch outside. First, we start with extremities. We actually go from the hands, see if they're
Yes.
okay there before we even go to the face. If they allow the parent or the therapist or the teacher to touch there, then we go about. They don't even allow that, okay, we're not going any further. We would work on
Yes.
that first to get them desensitized before we even get to the face. We can do it through a lot of play because children love to play. So when you play with the child and you kind of start building that rapport and the trust with the child, they are willing to allow you to a certain extent to maybe go tap tap tap, and make it a playful banter with them. They might allow you to do that. But like I said, it's a process to get from here to inside, and then slowly work on reducing that sensitivity. We use different tools for it. For those who don't have tools, so the thing is, if you start with food is very overwhelming. It has so many components. There's taste, there's
Yes.
temperature, there's texture to it. And for a child who's already hypersensitive, if you introduce food as a way to desensitize them, they might not react to it really well, and they might push you away more. So we use non-food items. We call a pre-feeding activities to help the child get desensitized, so that we can introduce food at a later point.
That's a very key message here. I think two messages. So you start from the extremities before coming to the face, and second is to start with directly with food is not maybe a good idea. You need to desensitize with other things. So Shireen, we
Right.
do have more questions, but I think this is the right moment because we are discussing about desensitizing. Do you have any tools that you would like to show us, which we can use for desensitizing?
All right. So one is your hands themselves, which you can use, because they need to kind of be okay with this before you put anything into their mouth. So we do tell parents that they can use their hands to just warm their hands up. Don't let it be really cold, because the temperature might be something uncomfortable for the child. So, kind of rub your hands and kind of, you can, touch their face. You can use cream on your hands. You can use oil on your hands to make it a smoother movement when you do some of the massages. So basically, the sensory component is taken care of with different kinds of massages that you do,
Right.
both outside and inside the mouth. And so when you go inside, we use something called a Z vibe, which has different attachments or tips, I would say. Yeah, that's a Z vibe that you can see on the screen. So it has different attachments, like the one you see on the screen. This is another one. And the attachments are not used at random. The tips are used based on the child's sensitivity and what the child is showing us. So each has its own function. So I would suggest not using it randomly, and to kind of understand why it's used. So this is one tool, for example. Another one that we use inside the mouth is called a toupette. I can just open one and show you. This is a toupette. It's an oral you can get it as an oral swab. They call it, it's available on Amazon as oral swabs. Dentists use. It's easy to get inside the mouth with that. You can use a Nook brush. I don't have a Nook brush with me, but I do have.
I think I have a picture of a Nook brush, so I'm going to add that.
All right. So, yeah, there you go. You can use that too. You can use this, which is the Infident brush.
Yes, okay. So that's the Nook on screen,
yes,
and I have the picture of this one too.
Yeah. I mean, it's something that's readily available in the market. We generally use this for the younger population and
babies,
not for children who have teeth, because then it will bite your fingers and it will really hurt. So suggestion not to use this for children who have teeth. When it comes to children who are, biting constantly, we would use either the Z-Vibe or the Nook brush or even the Arc Probe, it's called.
Okay.
So again, that you see. So again, how we use it depends on the child. So the Z-Vibe.
Sorry, I think
we went.
Sorry, Shereen. Yeah, I'm so sorry about that. Okay, there you go. So you were telling us about the Nook brush. Yes, we are back.
The Nook brush. Yes. So there are different. I mean, this is the Arc Probe, which can sometimes be used too. Although it's part of the jaw rehab program, we could also use it for the sensory massages. And the Z-Vibe vibrates, so we don't use it for children with a history of seizures or epileptic attacks unless the doctor has said it's okay, it's not a trigger. We need a medical report that says that vibration will not cause a seizure. So we have to be
children.
So we have to be very careful on using the Z-Vibe. We have to have the history beforehand. So these are some of the tools that you can use. If you look at everyday things, the kitchen towels that you have, different materials, dress materials, all of those can also be used outside on your face to kind of get more input. Because the whole the idea behind it is to wake the muscles up. It's either wake the muscles up or relax the muscles. So for children who have very low tone and you're not really feeling enough, you need to wake it up. For children who have spasticity or cerebral palsy, where you're like this, they're so tight, you need to relax the muscles. So the pace at which you do the massage, how fast you do it or how slow you do it also depends on the child and what they're showing us. So there's a whole lot of components there with respect to massages. Do I show the other tools too?
Yes, I think. Or maybe we just take a few more questions and when we come to.
Right.
So you did talk about desensitizing and using various tools and etc. So does it? I mean, is it challenging? Does it take time for a child to, overcome the sensitivity according to experience? I mean.
Yes, it sometimes does. The maximum I've had is 1 year before I could even introduce a tool. But then I would say that 1 year was also because it was very inconsistently done at home. So if it is done consistently, within a month, I can see changes and parents coming back to telling me that, oh, she's trying out this food now. She's willing to. Before she was on pureed food, put in the mixie, pureed, and now she's willing to try out some kind of solid food. She's okay with it. She's not gagging, etc. So definitely, you can see improvement sometimes week by week, month by month, or it might take even longer. It kind of depends on the extent of the sensitivity the child has. But what I've generally seen is if they're consistent and if it's done every day, you will see improvement fast.
Okay, that's good to know if there's some positive sign there. And so parents need to own these tools, whatever as suggested by the therapist.
Yes, they do. Because the thing is this, you go to a therapist maybe once a week, twice a week, even thrice a week. Twice a week is the minimum that you need to do an OPT program, because an OPT program is a muscle training program. Right? It's based on building the muscles. So like your therapists do it or the OTs do it, there is a whole, there's a range of muscle function that you need to kind of develop, the fine movements, including the fine movements. So unless they practice that every day,
Mm.
it will not develop as fast as you want it to, right? So
Mm-hmm.
minimum 3 times a week, maximum 3 times a day.
Okay, so it can go up to that much as well.
Yes, and the more you
but
do,
not more than thrice a day is what you recommend,
yeah,
roughly.
because parents don't have
It's
that
just
much time to do
the
it. I mean, it's
time.
too much. Yeah, yeah. Because the thing
Yes.
is, this is supposed to be done only for 15 to 20 minutes. It's just
Okay.
small exercise that you do, and then you move on to speech and feeding activities.
Right. Okay. Okay.
Okay.
That's good information. Okay, so we have Shama who has this question. How do we know whether a child with speech delay needs OPT? So I think we did
Um,
discuss about this.
yeah, so again, we'd have to
Yes.
look at whether the child has any sensory issues, whether they can imitate movements, whether they have difficulty moving from single movement to a combination of sounds. That is another way to kind of figure out. And so on. So there are a
Okay.
couple of things that we check, and I don't really wait for a diagnosis, truthfully, to do something. For me, if you can do it as fast as possible and start it off, it doesn't hurt. It just helps the child learn faster. So, but again, I check, does he really need? Can he imitate me? Can he do combinations? If he can do it, then no need. Why buy all these tools?
Yes. Yes.
Right?
Okay. So there's Hina again. I think she did ask a question before also. So what can we do if the child is not allowing to brush his or her teeth because of oral sensory issues?
Desensitization. That's what we would do.
Mm.
Right? Because the thing is, brushing is one of the main complaints that sometimes, or the concerns rather, I would say, that a parent has, that he's not allowing me to brush. And
Yes.
because of that, there's tooth decay, there's cavities, which creates a whole vicious cycle, because then we can't work on the jaws because the cavities are there, then they need root canal. So all in all, the feeling inside the mouth is so uncomfortable, I'm not going to create any movement. And so speech automatically gets affected because of that. So yes, the core of sensory, dealing with the sensory issues and kind of desensitizing the child is important. Like I said, those were some of the ways to kind of desensitize, outside and inside. You need to do it both, outside and inside. Unless the child has no sensitivity outside, it's normal, then fine. But we generally do both to just kind of, make sure that there is no underlying sensitivity issues. So how do you do it? It's a step-by-step manner where you desensitize the child. That it's like I said, is a program on its own. I don't think I can cover everything now.
Yes. So we'll probably have another event where we just go about the hows of doing it. We can talk about that later. But I hope this information is sort of helping all the viewers with their questions. There's one more by Kritika. So she says she agrees with you, Shireen. My son has weak muscles around mouth and jaw. Basically, he struggles to move his jaw. Sound production for some letters are fine. What are the basic oral motor exercises for muscles to improve his speech? So this is occupying a lot of the camera, so I'm going to hide it, Kritika, but I'm sure we'll address it now. So she wants to know the exercises to improve speech, oral motor, some exercises, some massages, if she can show us. Yeah.
Yeah. So the thing is, like I said, so there's sensory, there's motor, and then there's feeding and there's speech. You need to have all 4 components. So when we start with the sensory, like I said, there are massages to wake the muscles up. And the one thing that you all have to understand, sensory massages are done to wake the speech muscles up. It is not done randomly. It is not done, oh, let's just do this. Okay, muscles are woken up. No, this is not going to do anything for us.
Yeah,
right?
yeah.
When you do this, for example, you are working on stimulating those cheek muscles up to your lip muscles. And when you do this, you work on getting a rounding, which is needed for sounds like ooh, oh, and whir. Right? So all the massages you do, one has to be a forward movement, because speech is a forward movement. Speech is a symmetric movement, and speech is based on touch. So all 3 components are put together even when you do the massages. It is not random movements. So for example, if you're doing this, right? You're working on getting that lip to close for those especially who have open mouth posture always. But we see, especially in the Down syndrome population, they have always like this because of low tone. So stimulating those muscles, those lips to understand, oh, wait, I know I exist, oh, I can move. Otherwise, if the awareness is not there, it's very difficult.
Right.
Sensory part, which you would do the massage side, all right?
Then so do you use any specific, do you use any specific oils while doing it, or just with your hands is okay?
No, not specific oils. I tell the parents that you decide on, because some parents are very specific on what they will use on the child's face. Yeah. So I leave it to them. I say the cream that you would generally use, or the oil you would generally use, or powder you generally use, that can be used because each has a different texture.
Okay.
So there are 3 components for the sensory normalization: temperature, texture, taste.
Okay.
These are called our 3 T's. And of course we can't do taste outside, but that's meant for inside. But these are the 3 T's that kind of normalize the system.
Mm-hmm. Okay.
Right? Important information for all of you, because that's what you actually have to do to help with the sensory component. Then you would probably go into oromotor exercises per se, which could be blowing with whistle.
I think we'd like to see the tools. Yeah. Okay.
Yeah. It could be, but before that, let me tell you why we do this, if you don't mind me, coming in there.
Please. Yeah.
The thing is this: when we talk about speech therapy, when we look at traditional speech therapy, we go directly to the lips and the tongue and say, look at me, do what I do, because most of the speech sounds come with the lips and the tongue, right? But we forget one important component, and that's the jaw.
Yeah.
And the jaw is not really actively worked on, because when we were in college, when we learned, we didn't really work on jaw. We would all go to, okay, look at me, raise your tongue, do it this way, close your lips, do it this way. And we kind of, work on that. But actively working on the jaw was not really there. And I didn't really understand that component either till 8 years ago, on why it is important. You can try it out at home, because if you lock your tongue, right, if you say the tongue is the most important, and this is something I do in all my presentations, so I'm just to make you understand that if you open your mouth and you lock your tongue behind your teeth, okay, and if I have to count.
Oops, sorry, we lost Shereen again. Sorry, Shereen, we lost you. Are you back? Yes.
I am back.
Yes. You were showing us the tongue locking thing. Yes.
Right. Okay. So I was just saying that basically, if you say the tongue is the most important, right? And I'm going to just count 1, 2, 3 by locking my tongue, because you say the tongue is the most. So look at the clarity here. 1, 2, 3, because my tongue cannot move. Okay. Now I'm going to lock my jaw. Okay. And I can move my lips and tongue. And I'm going to say the same 3 sound. So which one is easier? Which one is easier to understand? The one where the tongue is locked. So it's not the tongue that's creating the clarity, it's the jaw. That's the base.
Yes.
Right?
That's a very good analogy. Yes.
Yeah, so that's where we have to start with the jaw, and that's what traditional speech therapy really doesn't actively work on. It might do it subtly, but it doesn't actively work on. So that's where we kind of use tools like the Chewy Tube.
Okay, I'll bring these up. So are you using the red? I have red, yellow, and the P in Qs. Okay. I have the red one here.
So that's the red Chewy Tube. Again, these are not used in random. They have functions, each one. So there are 4, which is part of the OPT program. There are 4 of them. It's not just one that will help develop the program. They're all 4 that are used. Depending on the skill of the child. All right. So what the Chewy Tube is, it's based on a resistance training program. It's bendable, but it has a little bit of resistance. So when the child or the client has to bite through, right? So when they do that, it kind of builds the muscle strength. You can change tone, but you can make the muscle stronger. And that's what we do.
Yes.
We try to make the muscle stronger. So one of the things we use is, I give you an example, is the red Chewy Tube, where you go, And we do that to a certain number. It has to reach a criteria of success before we introduce the rest in. So sometimes you could be doing all 4 at one time. I mean, in one set, you could be doing the red and the yellow and the green and the purple, all of them together. Or you could just be doing one because the child doesn't have enough strength. So, and you have to make it symmetrical. So if you're doing 10 here, yeah, bilaterally you have to. So here too. So you have to kind of work on that. And it's called a bite cube set. So basically there is a hierarchy to it. It gets from, the resistance goes from less resistance to maximum resistance. So this is the P-arcs P-grabber, the P-shaped thing, which is built in. And as you can see, this is solid, whereas the red chewy tube is hollow.
Oh, okay.
All right. So this is solid. So when you bite something solid, you need a lot more strength to compress it. So it works on a lot more resistance, and because of that, your strength increases, right? So it's all done in a hierarchical way to kind of build the jaw strength. Another thing that you might have seen when I see the jaw grading bite blocks, which are used.
I think I have them in the pictures.
Yeah, those are the jaw grading bite blocks, which you also use to, it's again based on resistance training. So, you know, when you have weights in your hand and you do this, right? You build the muscle here.
Yes.
It's weight that you build the muscle. It's the same concept here. With resistance, I build the muscle strength here. And if my muscle is strong and if my muscle is stable, I can move the rest of my structures. If the jaw is unstable, if the jaw is going like this, it's going to slide. Okay, or it's jutting forward, my clarity is going to go off immediately.
Right.
And the jaw controls a lot of the vowels. All the vowels are controlled by the jaw. Ah, E, U, O. All jaw movements. And if your vowels go off, 90% of your speech clarity is gone. Right? So where we focus traditionally on consonant sounds, we forget the vowels. And we need to put both together to have clarity.
Right.
So
that's very intriguing.
Yeah, and all these are working on very fine movements. The thing is this, speech is a very fine motor activity. Right? So it works on fine movement, fine control of these muscles.
Yes.
If you do not have that fine control, your clarity will get affected. So it's not that I can say not this way, but I can control to say I want to. There is a fine control of the muscles, and that's what is needed for speech clarity. And we don't. That's where she. So many years ago, she said that's where the clarity is going off. The mean length of utterance is improving. They can say 3 words, but by the time they reach that 4th word, I can't understand a word they're saying because they did not have adequate jaw strength to support it. Their structures could not support it. The fine control was not there. So
it makes a lot of sense. Yes, I think even individuals with hearing loss, I think, might really benefit from such a program because they miss out on a lot of understanding of the, as you say, the sensory part, and then moving the jaw in the right way. The feel. I think OPT is more about the feel of speech. That's what.
Yes, exactly.
Yeah, so the feeling what you're saying.
Right.
That's great.
So if you can feel it, you can move it.
Yes.
That's that. Yeah.
Yes. Yeah. So do you have any other tools that you would like to?
We have a whistle, which is a simple whistle. So again, there is a hierarchy here. There are about 10 whistles in the kit, and it's very simple to more complex horns. They call it the horn kit. So it is again in a hierarchy, mainly 1 to create movement, 2 to create what we call abdominal grading. Now, abdominal grading is also something that we kind of miss out on because when we need to talk so much in one breath, we need to release the air slowly. If we just release it like this, I will talk like this. I won't be able to control that airflow. So my abdominals will need to have a lot of fine control movement to release it slowly so that I can talk so much in just one breath. So what the horns do is try to build that abdominal grading to enough to support speech. Again, it's not to, to create any other, I need to have a phonation duration of 5-10 seconds. No, but enough to support speech. That's what they're looking at. That's why it's done in a hierarchy. Movement, I get, for example, with this one, I get lip closure. Because I have a lot of children who do this. They bite it. Now, if you're biting and blowing, that means you're not using your lips independently. You're depending on the jaw. And speech has a lot of separated movements. I can keep my whole body stable without moving, and I can just move my mouth. Right? I can separate my lips from the rest and just move that. I can move just my tongue. I don't have to do this. As my tongue goes up, my head goes up, and there are a lot of children who do that. And that's one of the first things that we should give you an idea. There is no separation of movement, which might affect the clarity. Because in isolation, you might be able to do, but the minute you put into a word in a sentence, that will go off. Because this is physically tiring. If I have to keep doing this. And if I get physically tired, I'm not going to talk clearly.
Absolutely.
Yeah. So there are a lot of things so each horn works on different movements, and you work on a criteria where you work on it fast. For example, because the other thing that you're trying to build is a memory. Speech needs the memory, a muscle memory to come in. If there's no memory, I'm not going to remember what to do the next time. So when we walk, we just walk. We don't think about a left leg going or a right leg going. We just do it. The same way, speech needs that much practice that it becomes a memory, that it becomes automatic. So the automaticity in the movement is what is worked on from the start, because at the end of it, that's what's needed in speech.
Right. No, it makes a lot of sense. Absolutely.
Yes, that's, and then you have a lot of straws. Again, you have different kinds of straws. As part of talk tools, I'm just showing you a few.
Yes.
Right. Again, working on movement. Yes, you have the entire kit there in the picture. Everything works on a movement for the jaw, for the lips, as well as the tongue. It is not isolated to. It is not sucking as a skill. It is not blowing as a skill. Because even when I talk to therapists, this is what we've been taught. I mean, this is traditionally what we've been taught, that it's a skill, a vegetative skill. You need to learn it, right? But why do we need that skill? How is it connected to speech? Are you translating it to speech? That is something that needs to be understood.
Yes.
So if you have a straw, you get lip rounding. If you get lip rounding, you get ooh, oh, were. You get tongue retraction, or the tongue moving back and stabilizing the. Yes, because it needs to be at the back to help in continuous speech, or what we call co-articulation also, right?
Yes.
So there is a lot of components there that are worked on subtly through these tools. So one tool will have 10 goals. It will work on 10 things in one shot.
Right.
So it's not just work on one thing. So that's the thing, the beauty of it. That's what I really liked about it, that it's not just working on one thing. Even with the Chewy Tube, I'm not only working on the jaw, but I'm working on the tongue moving at the same time. Lateral movements of the tongue starts.
Yes.
So those are some of the tools that I used.
We have a few more questions coming in, Shereen. So there's Vidya. She says, children above 15 years, how well do they respond to OPT, because they are older and they're teenagers?
Well, OPT can be done from birth till you die. It's like a muscle program, so you can still train the brain to kind of create those movements. But in terms of cooperativeness, something you'd need to work with to kind of get them to understand what needs to be done. As a routine has to be set. You might need to use motivation, external motivation if necessary. For some of them who are older, you can explain to them why you're doing this, for those who can understand what's happening. Right, on why you're doing this and how it's going to help them. So you can work with teenagers. It has been worked with teenagers. It has been worked with pediatric teenagers, geriatric population. you can span across ages. It's not limited to one age group, but it's all about the motivation to do it. So it's up to us to kind of build that motivation so that they will do it.
Yes.
Yeah.
Mm-hmm.
So that would be the answer there.
Okay. Yes, and there's one more from Purna. Yeah, if a child is speaking all consonants and vowels separately, but not in sentences, how to go about helping such a child?
Child is speaking all consonant vowels separately, but not in sentences. So when you
Maybe
say
he's
all
not
consonant
joining them
vowels,
in words. Yeah.
yeah, probably. So the next step would be to see whether can they sequence out the sounds. Can they go from a per to an r to make a pa, or a per to a u to make a poo? If they cannot do that, they might have motor planning issues to be able to do that. And if they have that, then we go back to the tactile component to teach them to go from one sound to the other. One example is the apraxia program that TalkTools has, where they use some, they're called apraxia tools. You can just give me a minute. So, for example, this is tool that they use for p, and this is a tool they use for o. Okay, because this gives a tactile component on how to produce the sound. Now, when the child is able to do it in isolation but not combining, we start teaching them in a tactile way how to combine o, rather than just look at me and do it. If they can do it with imitation, great, then we work on that. But if they can't do it on imitation, we would bring the tactile component in to kind of get them to understand how to move from one sound to the next, and then move on to words and sentences, etc.
Yeah, I think that's a great answer, and I think those tools that you showed just now, I think I'm sure Puna has understood a bit through that. Shireen, one question I had. So I've seen a lot of children who have who drool a lot, who have excessive saliva. So any tips that you have worked with, and that really made a difference to that child when it comes to controlling the drooling?
Right. So the first thing is to kind of understand why the drooling is happening and working on those components. So if you look at why drooling happens, it could be probably an open mouth posture. It could be that the tongue is not taking the saliva back for the swallow.
Yes.
All right. So there's no tongue movement. The jaw is open, inadequate closing of the jaw. Lips are not closing. So all three components are affected. So what we need to do would be to strengthen the jaw so that it can go back into closure position, to work on the lips so that it gets lip closure, and to work on tongue retraction. And one simple example of doing that is if you do this. If you do this, jaw is closed, lip is closed, tongue is back.
Yes.
This one activity can create all these three movements, which help the saliva to go back because the tongue is slowly starting to move then, right? And then you stimulate the swallow. So it's about first strengthening the muscular structure so that the jaw, lips, and tongue can actually move. Because if it's not strengthened, they won't move.
Right. No, I think that's good.
So different kinds of activities like that would help with drooling.
Okay. So do you also recommend massage for
yes.
drooling?
So again, that was the oromotor part, but definitely there's a sensory part also. Because if there's lack of awareness that I don't know I'm drooling, I don't know my mouth is open, I don't feel it, I don't feel saliva all over my mouth, then I need to create that feel first. Like you said, you need to feel something.
Yes.
Right? When your leg is numb, you can't walk. You will shake it up, to start the walk. It's the same concept. If I don't feel, I won't create movement. So that's one of the things that we have to do. We have to create that movement. We kind of, wake the muscles up, create that movement, give a lot of different temperatures, textures, and tastes if they're okay with it. And create that awareness and then put oromotor activities so that you create movement and then put it into speech or feeding.
Right.
Say, for example, sorry to interrupt you. Just connecting feeding to speech, because a lot of parents ask me, why is feeding and speech connected? How is it connected? Right?
Yes.
A simple example is if you drink from a cup or you eat from a spoon. If you eat from a spoon, you have to close your lips to clear the spoon, and not your teeth, but your lips. So every time you do that, you're creating lip closure. And if you have lip closure as a movement, you are able to use per bum as sounds. If you do not even have that lip closure, I cannot even work on per bum as sounds. So feeding is a prerequisite for appropriate speech sound production.
Right, right. So do you, I researched a lot on OPT, and I got to know that probably, the principles, obviously, you've explained very well. So do we need to start with feeding first? Like, should we start with feeding first before coming on direct
Well,
speech?
again, it depends on, feeding is definitely a more natural way to go about it. But now take an
Mm,
example of a child who's so sensitive about food or he's choking
mm,
on food. You can directly
mm.
start with feeding,
Yes.
right? So that's where you would look at non-food items to kind of build that strength and the movement so that it can be translated to speech. But if a child is able to eat without too much issues and you want to build, say, example, you don't have the tools and you can't buy the tools or you can't afford to buy the tools, you could use feeding then as a way to get a lot more jaw grading and control movement of the jaw when you bite at the molar area.
Right, right,
You
right.
know, you can
So we have
create structure.
yeah. Okay. We have a lot of questions coming in with just a few minutes to go. But I'll. Oh, that's amazing. Thank you, everybody, for such a lovely response. Okay, let's. So, yeah, so this is a valid one by Vinita. She says they are expensive. How can we counsel parents on on maybe not buying, or maybe what is your take at that?
Well, I had a problem for 8 years and I continue to have it. So that is something. But now I find that a lot of parents have understood and so they're willing to kind of spend that amount of money. But for those who can't or don't really think that they can do it, we kind of try and start with what's available in the markets, like different kinds of straws we try and get. We try to get simple whistles that are available in the market. But the thing is, you have to use it in a way where the rationale is connected to speech. Don't randomly use it, nothing is going to happen with it. And you cannot call it an OPT program if you don't connect it to speech. Right?
Correct, correct.
So one of the things that you have to be very clear about that, okay, I'm going to use a whistle. I can't afford to buy the whistles from Talk Tools, but okay, if I use a simple whistle, what am I creating? How can I translate that to speech? That's what you need to
Right.
understand and what you need to counsel the parents on. And I think once you kind of do it with the parents a few times and they see improvement, then maybe you can talk to them about investing in a little bit more to make the movements more fine and more controlled. Because you can only control it to a certain extent with the regular stuff that you get in the market.
Correct. But Shireen, I think, whatever talk tools trainings that you have received, you are certified to use them and work with parents. But so
Right.
say, I'm sure, many of our viewers today are based all over the country or maybe around the world, and they do not have a therapist nearby, a qualified
Mm-hmm.
OPT therapist. So what
Right.
suggestion do you have for them?
Well,
They
you can
can come down
find.
to Bangalore.
No, you can always. The thing is, there is a website where you could probably find therapists, even if it's across the world. Talk Tools also puts up therapists' names up online if they've passed
Okay.
a certain certification because they know that they've observed them, they trust them to know what they're doing. So then their names go up. So across the world, they do have that. Within India, there are therapists who have been trained on OPT, part of level 1, part of level 2. So they have some idea about it. So you can get that information. I think Help Them Shine has that information. Then Minu Surgicals has that information on which therapist came. So I think if you reach
Okay.
out to them, they'll be able to tell you
Okay.
where therapists are. And
Okay.
it's one of the reasons I started an online program because there were parents who were in the US who were contacting me, in Thailand who were contacting me and stuff. They're saying, I can't come to you, every day. I can't do this. So I said, yeah, definitely. So we created an online portal where we kind of had meetings with the parents with the tools. Only the assessment needed to be face to face as much as possible. And the
Yes.
rest kind of made it in a way
The
that they could work
program could be.
a home program that they could use that works too. So again, it depends on what the parent is comfortable with. Some parents are not comfortable with them doing it. They're more confident if the therapist does it.
With the therapist doing, yes.
Yeah.
Yes.
But there are some parents who
Yes.
say, no, I want to do it. My child is a lot more cooperative with me. I said, good.
Me.
I'm very happy if, as a parent, you can do it, because at the end of it, your child, you know them best, you can understand, and they will be more motivated with you.
Oh, yes. So we had a question on getting certified on OPT before. The first question that we had today in the live event was that. So where can somebody get trained?
Right. So there is, Sarah herself is coming down in January to Mumbai.
Okay.
For the level 1 training. So because I attended the one that when she came to Delhi. Although I was certified, I went to see her, hear her talk live. And I will tell you, it's an amazing experience if you can get the training directly from her.
Yeah, absolutely.
And she's coming to Mumbai in January. The dates are not fixed, but you can contact Tushar from Menu Surgicals. He's the one organizing it. He would be doing it. And you can, contact them. I just directly tell the therapist, contact him and find out. I don't have the dates as yet, but he would share the dates, and we will share that information too on our web pages and stuff.
Okay.
But there are also who cannot come. There are online courses on TalkTool's website where you can pay, and it's on demand, and you have access for the whole year, so you can come back to it and repeat again and again. There is a book available in addition to it. Sarah has got a book available called Oral Placement Therapy, which has a lot of the activities in it. But again, you have to understand how to put it together. Don't randomly take it and pick out activities, because there is a lot of criteria on when you move to the next exercise. If that is done wrong, the program will fail. So that's one of the things you can do. So either live, do it online. You can buy DVDs and do it at home. They accept all of it. TalkTools accepts all of it.
Right. So Shereen, we have more questions coming in. Yeah, I think we just give 5 more minutes. So we have probably, if you can just quickly touch on the main core thing that the viewer wants to know. So Mr. Ray wants to know about a 4-year-old ASD constantly grinding her teeth. So is it sensory? Can be helped?
Yes, it can be helped with OPT. The reason they grind their teeth is because of a lack of input in their TMJ, or temporomandibular joint. This is the seat of stability. This is where they get all their input. If they don't get adequate input, they start seeking input. Grinding teeth is one, mouthing is the other, screaming E is another way. So there are different ways that they do it. So you need to give the input. That's the core. So when, for example, you use the chewy tube, you start stimulating that area. When they chew harder food, you stimulate that area. So there are different ways, and OPT does help with it.
Right. And we have a lot of overlapping questions, things which we have already answered. Gagan, you say severe autistic. Okay, so Mr. Gagana, she wants to know about how OPT for severe autistic children in terms of feeding and vegetative skills both.
Yes, you can. Can we go about OPT? Yes, you can go about OPT for any population, whether it's severe or not. It's about creating those movements. But again, if you say they have behavioral issues, that's another thing that you need to work on to incorporate this in, right? So you need to kind of, again, set a routine. So there are different things that you can do, but can it be used? Yes.
Right. And minimum age, Trisha wants to know. So, as small, she says minimum age to start.
Neonates, when they're born in the NIC, we can start with creating jaw movements from then itself.
Wow.
Of course, we won't go to the straw and stuff like that. We will look at creating
we'll look at the tools on maybe what components you can use.
And tools. It's just your little finger that you use to stimulate. Yeah.
Absolutely. So Tabitha wants to know, it helps with feeding and sensory, but no direct impact on speech sounds.
Yes. So this was the we discussed earlier.
We did talk about this. Yes.
Right. So does it help? Like I just showed you, feeding. If I have spoon feeding, I don't know if I have my spoon here. I didn't take it out, but if you can give me a second. Okay,
Yes,
so
yes,
suppose you have a spoon, right? If I can just find it, just give me a minute. If I can just show you something, then it might be, you may be able to understand it better. All right. So taking a simple spoon, this is just a regular spoon, okay? Now, if I were to place the spoon this way, and I get the child to eat, and clear the spoon, I'm creating lip closure. If I'm getting the lip closure and then I can get it on demand, close your lips, I can work on If I had to change the spoon placement and do it this way, front placement, I'm doing rounding to clear the spoon. So I'm working on getting a little bit of lip protrusion, and lip protrusion is useful for oo, o, and were, for example, right? So again, it creates movements, but we need to translate it to speech, and that's where OPT comes in. It's not a non-speech movement. It's not that we just do this and say, okay, you're done now, oo, o will develop. It's about, okay, I see the movement, now let me take it to speech, because I see the movement coming automatically. The important part. So you need to put it together. Then it does work. Alone, it doesn't.
It doesn't work. Right. So again, I have a lot of questions here which are overlapping. We've already sort of touched base with those items. Shalini wants to know which Z-vibe attachment should be used in desensitizing a child.
Well, initially we would use this one because it gives less input. It's called a yellow prefer tip. But again, depends on also the child's mouth. If you're working with a very young child, I would use a smaller tip because you can't put something really big into their mouth. So that's where the size of the tip also matters. So again, to give you a very general answer would be very difficult, or rather a very specific answer would be very difficult. But I would say this gives less input for a child who is very sensitive. We would start with something like this, which gives less input, and we would switch off the Z-vibe. We wouldn't use it with on position because it's very intense. Yeah.
Yes. Okay. So there was another one asking for drooling. I think we covered that extensively.
Right.
And by the way, this is all getting recorded, so you all can view it again and make notes and get more answers as you watch it again. How to teach a low muscle tone kid sucking from straw. I think we had this similar question on sucking even sent to us since past 2 days. We've been collecting questions. So yes, this was a general concern.
Right. So there is, to teach sucking, there is something called a honey bear that they use. It works on the same concept as a Tetra Pak. When you squeeze a Tetra Pak, now this is the bubble bear.
Okay.
There's something called the honey bear.
Yes, I think there is one, but I don't have a picture. Yeah. Okay.
So this is a honey bear, right? So we use this to kind of teach sucking. Again, if the parent is not able to buy it, of course, we do use other methods to kind of teach them how to suck from a straw. The thing that we need to understand is first, does the child have lip closure first? If the child does not have lip closure around the straw, we won't teach sucking yet. We will still work on the lip closure. So if the child is not able to close his lips around the straw and he goes things of the sort, we're not working on the sucking. We're working on close your lips, take it out. Just close your lips. So it is broken down into components where the child can achieve something, and then we move on to the actual skill. So whether it's blowing or whether it's sucking or whether any of these vegetative skills is broken down to what the child can do, can achieve, can feel good about himself, and then we move on. Right?
Yes. Right.
So, to teach you how to teach sucking, it's a little difficult in 2 ways. You can do it.
Yeah, I think breaking down, knowing child's strengths, and then taking from there is the key takeaway. So it's all very customized.
It is, yes.
Okay. What OPD strategies you recommend for children with apraxia? I think we did touch base on most of these, but maybe a quick one, Shereen.
Well, again, tactile way. If the child with apraxia has issues with imitating, which is mainly where they have issues, planning, sequencing movements, then that's exactly where we use a tactile component to help them understand. Instead of just saying close your lips, say, we actually bring this in to say close your lips. Now, this is after they have lip closure as a movement. So in the whistle, they bring lip closure. They're able to clear the spoon from with their lips. That's when we introduce this, to be able to get that air out and to be able to get lip closure at the same time for a right. So again, tactile component coming in to get them to learn that, and then we go into combinations, and then we move on from there. And once they're able to do, because one of the components of their Praxia program is to get to imitation, and if you have imitation, you can work on traditional approaches then.
Right. Yes, absolutely. So I was just trying to skim through the questions that we've received through the Google Forms, and I think we've covered most of the items. We really thank everyone for sending questions and making this highly interactive. So is also for dysplasia or dysarthria OPT?
Dysarthria, yes, definitely, because it's weakness. OPT works on that part of it also. So yes, it does definitely works with dysarthria. And for children who have dysarthria and apraxia, also helps. So again, it could be all, it could be one, it could be both, it could be different components. So we look at that.
Okay. And what about verbal stimming?
Okay. There are a lot more components there that we need to look at. Because sensory issues, it need not be limited here. It could be a lot of things. It could be auditory seeking when they're verbally stimming. But if a child is going, a lot of times it's because they're stimulating, like I said, their TMJ, their temporomandibular joint. So when you start giving them enough input there, a lot of that stimming starts reducing.
Okay,
so
that's wonderful.
Yeah. So, but you have to know whether it is that or not, or it is an auditory, that auditory input that they're seeking. So we have to kind of see.
Okay. Yes. So there's a lot of thank yous coming in. Very informative. Thank you. Informative. Thank you. I'm sorry if I miss out on showing anybody's comments. I'm trying my best. Okay. Thank you, everyone. And there are lots of thank yous coming in again. The whole purpose of having this interaction was to really share knowledge. And I think, Shereen, it's been, I'm really thankful that you agreed upon coming and doing this speech hour with us. There are more questions coming in, so I think we've already answered most of the things. Thank you. Will it be available for downloading? Yes, you can view it. It'll be always on our Facebook page. It'll also be put up on our YouTube channel, and you can always. Okay, thank you. Does loud vocal stimming be reduced? I think we did talk about stimming and using the temporomandibular joint. Okay, there's a new one that's come up. My son sleeps with mouth not properly closed. Can OPT help?
Well, we'd have to look at the jaw and see is there other issues with the jaw before I can actually answer that question. So we'd have to look at is there any weakness in the jaw? Why is his mouth open? And look at the core. If the core is solved, you would after some time see his mouth close during sleep too.
It could also be adenoids or somebody, the children not sleeping with. Yeah, it could be anything really. Why the child is.
There could be a lot of things there.
So yes.
Need not be just OPT alone that would help.
Yes.
So I would say go check with an ENT doctor if there are any adenoid tonsillitis issues. And if need to get them removed, then you need to do that because a lot of movements start developing. And you need to look at, like I said, the jaw. You need to look at whether he's a mouth breather. Is his nose blocked? Does he have a deviated nasal septum? What is happening? So there's a lot of components you need to kind of look at before you say, okay, it's because of weakness or
yes. Yeah. And a lot of thank yous. Thanks again for all the appreciation. I think we'd like to close it now. I'm going through the questions again. Looking forward to more sessions. Thank you so much for all the support. And Shereen, once again, thanks a lot for your time.
My pleasure.
We hope that this has added value to all the viewers, and we look forward to getting your feedback. What we've done at One Special Place is that we've compiled these frequently asked questions in an ebook, and we've put it on a store for a free download for all of you. I'm going to put down a link here. You can download that. We'll keep updating the book as and when, because we've had some very exciting questions come up today as well. So please feel free to download the book, and you can share it with your friends, colleagues, and your, whoever you think would be benefited from OPT. And Shereen runs a wonderful group on Facebook herself, and we would like to share that with you. She keeps posting some videos and answers questions on a regular basis in that group. We'll also send you a link to join the same. And thanks once again. It's bye from my side. And Shereen, any last message or anything that you want to share?
I just want to say thank you, and I hope I didn't bore everyone with the 1 hour of non-stop.
No, I'm sure.
Thanks so much for the opportunity to be able to kind of share this approach, and I hope you all benefited from it. And reach out to us if you need more help. Yeah.
Yes, absolutely. Absolutely. We're always here to share what we know. And thanks once again. I'm Pratiksha Gupta, founder director of One Special Place. And we look forward to making this platform a more engaging and fulfilling one for all of you. Thanks. Please download the ebook, and you can join the various groups that we run. Bye-bye. Bye, Shereen. Thanks for your time.
Bye.
And I look forward to meeting you again.
Yeah. Thank you. Bye-bye, everyone.
Bye. Bye.